Hello, everyone. Good morning or good afternoon, depending on where you're joining us from. Welcome to our third session of our Learning Collaborative on exploring cultural competence and humility in the care of HIV patients. I see that we still have some participants joining. Thank you. Thank you so much for joining. I will kindly ask everyone to please mute your line. If your line hasn't been muted yet. Thank you so much. All right, let's get started. So in today's session, we will be focusing on cultural competence models for Hispanics. This is just a kind reminder again to all participants to, usually you would be muted upon entry, but if your line is not on mute, we just kindly ask to please put it on mute. That way we don't have any interruptions throughout our presentation. We will have a chance to share some dialogue and provide some discussion engagements throughout the session today. Also, please make sure that you engage in the chat. Raise your hand if you would like your line to be unmuted. This meeting is being recorded and the slides and the recorded link will be sent to you all via email after today's session. This is just some background information about NCHPH in case you're joining us today for the first time. The mission of the National Center for Health and Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing a range of training and technical assistance. NCHPH is a project supported by the Health Resources and Services Administration and is a national training and technical assistance partner that is 100% financed by this grant. The information presented today are those. And today we have Dr. Jose Leon, who is the Chief Medical Officer at NCHPH. He will be basically facilitating for the most part today's session. And I will be also helping facilitate the session for today. My name is Filipina Sandoval, and I am the TTA Manager here at NCHPH. So before we begin, we'd like to do a quick icebreaker. And for the icebreaker, what does your perfect breakfast look like? Please provide your responses in the chat, or you may also raise your hand and we can unmute your line. Yes, lots of coffee. I agree. It can be anything as long as it has coffee, right? How about you, Dr. Leon? Do you have a perfect breakfast?
I do. I usually have oatmeal and fruit.
Mm-hmm.
I see that many are sharing my my favorite breakfast.
Yeah, awesome. Eggs, pancakes. Eggs Benedict. Yeah, for me, I would like to say crepes. I don't know if I'm saying it right. I'm sure there's like a better way of saying it, but I love it. I love the Nutella and banana and strawberry crepes. All right. Well, thank you all for providing your response. All right. So to continue, here are our learning objectives for today. In today's session, we will review cultural competence basics. We will also be revising culturally appropriate strategies to use in HIV clinic settings. We will be discussing the beliefs and traditions that impact the care of Latinos living with HIV. And now, without further ado, I will pass it on to Dr. Jose Leon to continue with the session.
Thank you, Fide. Hello, everyone. It's always my pleasure to be part of these conversations. We are learning a lot. This is our third session, and we've been going through many different topics and many different issues related to cultural competency and cultural humility. In session one, we reviewed the basics. We went over some case studies. We saw a picture. We have a lot of interaction from the participants. And in session two, we learned from a health center, La Maestra and Dr. Tessier, and we also learned from Linda. Those two interventions were very well received. Thank you so much for those who participated in the post-activity survey. And we learned from Lisa about the topic we're concerned that sometimes we don't keep in mind, and how we help our population who are deaf. And that was a really, really nice activity. Today, we are going to review some of the Latino community cultural aspects. And in our last session, next Wednesday, we are going to hear from another health center located just on the US-Mexico border. They have a very diverse community and a very diverse population, and they are very happy to share with us their experience and what they are doing to address cultural competency. So thank you so much for being here. These are the learning collaborative expectations. I know that you are very familiar with them. We are all learning together. We have multiple questions and we can make mistakes, and that's okay because we are learning. We know that we have different background and different professions or professionals attending these learning collaboratives. So please make sure that we respect our differences here. This is what the topic is all about. So thank you if you participate. And remember, and the last one is my favorite, the participants, the SMEs, and the facilitators all are learning from each other. So let's do this a collaboration and interaction, and let's learn together. Next slide, please. So we've been reviewing some case studies about sex worker, and now we are going to close that with this true or false. We have some questions here. So let's go together and see what the responses are. Again, remember that there is no 100% accurate response because we see differences from different angles and different perspectives. But let's see how we can get together through these questions. The first question is, sex workers love money and are too lazy to work. They could easily get other jobs. True or false? You can use the chat box for this exercise, and let's see whether we agree on these statements. I see already some false. And that is correct. The answer is that this is a false statement. Remember that our patients in general are affected by social determinants of health. Many of them may be unemployed. Many of them are low income. Many of them have no insurance. So this statement, we are stigmatizing people just by their profession or by what they do or the activities that they perform. So let's do the second one. Sex work is the quickest way for poor women to make money. True or false? I see some false. And I see false. I see Darla saying true. Lorena also saying true. This is a false belief. With this one, I had some issues. To me, this one is like a true, but also can be a false statement depending on how we analyze it, because if you are unemployed and if you have the needs to put some food on the table, probably this is going to be the quickest way to make money. But at the same time, it's not the only factor. So even though the literature that we review says that this is a true statement, in reality, and in my opinion, and I share this one with many of you, this can be either true or false. Third one, HIV is the only serious problem sex workers face. Some sex workers use alcohol and or drugs as a mechanism to cope with the hardship of their job. True or false? This is a false statement. It is true that HIV is one of many of the issues. And even though it's true that the consumption of alcohol and drug is more frequent in this population, the statement is a false statement. Let's move on and let's do the fourth one. Sex workers hide their work to avoid being stigmatized by their families and the community. True or false? I see many truths, and that is correct. The right answer is this is a true statement. Stigma is a big concern, and not only in the community, but also in the healthcare facilities. We learned from the last case study about a sex worker who went to a clinic, and this person was stigmatized. So let's move on. And the next one is sex workers are promiscuous. Their relationships never last. That is correct. The answer for this one is false. They have long-lasting relationships. This is a social issue, and but outside of the profession, the sex workers have long-lasting relationships. Now, the next one, sex workers are highly vulnerable to HIV because they find it difficult to negotiate for safe sex with clients and their full-time partners. True or false? This statement is also true. It's very difficult for sex workers sometimes to make the other to wear a condom or to use a condom. So this is something that one of the main concerns, and they are more vulnerable not only to HIV but any of the STIs infections. Next one, when sex workers come to a clinic, they receive the same treatment as everyone else. In many countries, sex work is illegal. True or false? That is true. In many countries, sex work is illegal. And the very first statement, we discussed it, and ideally, everybody should receive the same treatment, but we've learned during our last session a case where the clinic and the staff were stigmatizing the patient. And the last one, sex workers are afraid to report to the police those cases in which they have been beaten or raped by their clients because their works is illegal and they think they have no rights. True or false? And I see many truths. Yeah, and this is also a true statement. Thank you so much for participating, and this has been very dynamic. And we have learned a couple of things about sex workers and how we can be more culturally competent when we have our conversations with sex workers in our clinics. Next slide, please. So what is the problem when we are stigmatizing patients? We've seen this case of this sex worker that we analyzed last week. And what is happening when we stigmatize patients is that they don't come to the clinic, and then there is a lack of access to treatment. There is a risk of for personal safety. Specifically, we are talking about mental health issues. When we are stigmatizing, we also learned in session 1 that we also have our own beliefs on how people, the perception that others have about us. So that can create anxiety and depression, and that can lead to a risk of personal safety. And then lower quality of care. It means that if a person is not coming to our clinic, if they are missing some of the appointments, then the quality of care is going to decrease due to the stigma that sometimes that we don't know that we are stigmatizing patients. But these are the main concerns when we stigmatize patients. Next slide, please. This is not an exercise. This is just something that I was doing yesterday. And while I was watching TV last night, I also was reading an article on the Journal of the American Medical Academy. And I found this statement to me is very true. And it's just, I'm bringing this up because I want you to also think about not only to think about cultural competence, but about our patients in general. And not only about stigmatizing, but knowing that we are taking care of our patients properly. A patient is nothing better for a patient when they are in the clinic and they are anxious to hear from the providers their names. We cannot refer to them as the patient. So this is something really interesting. Quite sure that you are reading this, but it was written by another doctor whose mother was in the ICU, and she heard about a resident calling her mom a patient. And sometimes we are very busy. We have plenty of things, we have other things to do. We have under a lot of stress, but let's make sure that we also name our patient by their name or the first or last name. We are going to learn later about how we need to refer to the senior population, the Hispanic senior population. But keep in mind that sometimes we are dehumanizing a medicine, because sometimes we are referring to people as the patient or the patients. We are referring to the doctor, the nurse, the medical student, the resident, and we forget that behind that title, there is a human being. There is somebody who is also looking for some time of affection from us. So I was reading this, and I bring this up because in addition to our cultural competency and how we can improve it, we also need to think about our patients in general, not only those with HIV, not only those with diabetes, but all patients that we see every day. Next slide, please. So how do we develop cultural competency? First, we need to accept, that we are different, that nobody, the world will be very, very sad and monotonous, I guess, if we were just, if everybody was the same. So let's make sure that we are practicing openness, that we know that we are different, that we know that even in the healthcare facility, we will have staff who are going to be different, either because of their race or their ethnicity or the language. But let's practice some openness with our patients and with our staff. Next slide, please. I'm sorry, next one. Be flexible. We need to demonstrate that we are accepting that we are different. Not only the openness that we accept the different, that we are different, but also demonstrating that we are different. We need to be sensitive. We need to practice cultural humility. Next slide. We have to show some spirit of adventure. It's like going to another country and knowing that we are going to face with other people, with other language, with other culture. Is the same when we are taking care of our patients. And sense of humor is really good. Sometimes we need to see ourselves in the mirror and practice some sense of humor. Practice, hey, what I'm doing is wrong, and joke about ourselves, making sure that we understand. And this is a very nice way to make sure that we are learning that we are all different. And we need to practice positive change. Let's make sure that everybody is identifying the culture, learning from the other cultures, that we see their patients who are totally different. So that I think that this slide shows really good tips on how we can develop cultural competency. Next slide, please. We have other strategies. We've seen now that we are using pronouns. When you receive an email, when you send an email, people are making sure that we know how to identify them. We are not identifying people by their voice or the way that they dress, but we need to identify our patients the way that they want us to be identified. So let's make sure that if someone is referring with the she, her, hers, or he, him, his, we are making sure that we are respecting that part of our patients. And let's make sure that we have welcoming environments. Let's make sure that we have all the sickness that we need, that making our patient comfortable when they come to, especially to an HIV clinic. Some patients are anxious. Some patients receive undetermined results, and they have to go for a Western blot, for instance, or any other HIV test, and that causes anxiety. Let's make sure that we have an environment where patients feel that they are welcome. Next slide, please. These are the cultural competence basics. There are a lot, but I just want to highlight that it's not only the staff, the doctors, the nurses who need to change, but the facility as well. We need to make sure that we have an environment that is friendly, where people or our patients feel welcome. And when they receive all the information that they need, just by accessing the all the environments within the clinic. Next slide, please. All right, another true or false. It's time for another true or false. Now we are going to discuss what do we know about MSM. So the very first statement is, let's get ready for the true or false. The first statement is, becoming gay doesn't just happen. Rather, men decide or learn that they want to be gay. True or false? That's exactly right. That is a false statement. is a lot of information, and nobody really can get or can identify and why we have so why some people are attracted by the same sex. So there is something that is biological, social, and it's not just that somebody makes the decision, that he or she wants to be gay. Now, MSM, in this case, MSM are mentally ill that they can be cured. True or false? That is correct. That is a false statement as well. This is not a behavioral or mental condition. Again, there are several aspects. In fact, the DCM-4 took out the MSM on the lesbian and gay or the homosexuality as a health condition, and that was omitted. It seems that the DSM-5, I think that's the most current. There is no mention about any a mental condition on homosexualism. Now, the next one is sex between two men is against religion. This is a tough one. So who is true or false? This one can be interpreted as a true or false. We are going to see that in the Hispanic culture, many practice the Roman Catholic religion and the Christianism. For some of them, or for some of these churches or institutions, is illegal. However, there are others accepting these issues. So it is, I can say that is depending on your beliefs, it can be either true or false. Next one, MSM have been too influenced by Western values. True or false? Is false. MSM and homosexuality have existed for centuries, and this is not something new.
Toda la vida.
So this is nothing new. So it's not as being influenced or has not been influenced by Western values. I heard somebody. Anybody has any comment on this one? All right, let's move on. MSM are all the same. You can identify them by the way they dress and behave. This one is false as well. Not all MSM are equal. Not all the same. MSM have the same behaviors. We have many. I mean, the community, the LGBTQIA+ community has grown, and because there are several ways that our patients can identify themselves. Now, in many countries, it's illegal for men to have sex with men. True or false? Yep. Thank you for participating. This one is a true statement. In some countries, it's illegal for men to have sex with men. Now, the next statement, MSM have an increased risk of getting HIV and other STIs because of having unprotected anal sex. True or false? Thank you. And this is a true statement as well. MSM engage in the same sexual practices as other couples. True or false? That is correct. It's also true. MSM do not want long-term partners. They want only casual sex. True or false? That is also a false statement. There are long-lasting relationships in the MSM community, in the gay community. So this statement is false. And the last one is MSM may also have sex with women. True or false? And this is a true statement as well. And thank you. You are very knowledgeable. You know your patients. You know the LGBTQIA+ community, and what is behind the behavior and the conditions and the environment that they sometimes are affected by. Next slide, please. Now we are moving and we are transitioning over. We are going to focus now on the Hispanic population. And this is our first case study. Frida, please.
Yeah.
Go ahead.
Thank you, Dr. Leon. All right, so for our first case study, Alex is a 26-year-old Latino who has been married for 8 years. He has a wife and 3 young children. He's returning to the clinic for his first follow-up visit after receiving an HIV diagnosis the previous week. And upon interviewing Alex, the provider asks him if he has shared his diagnosis with his family and if his wife has been tested. Alex responded that he has not shared the information about his HIV status yet because he is afraid that his family will reject him. And also further discussion about how Alex contracted HIV revealed that he has been engaging in unprotected anal intercourse with other men in the evenings when he gets off work. He does not want his wife to know about his diagnosis. His wife has never been tested for HIV. He self-identifies as heterosexual and says that he only has sex with men because it is something new and different, not because he is attracted to men. He says that he loves his wife and his children very much, but he does not want to hurt them. So here we have a few discussion questions that we would like for you to think about. We're gonna give you guys maybe about 5 minutes, Dr. Leon. Is that an okay time?
Yeah, 3 to 5 minutes to go over these questions, and then we can go back and discuss the answer for each of these questions.
Excellent. All right, so we're gonna give you guys like 3 to 5 minutes, read over these questions, and then I'm gonna be going back to the case study as well. That way you can take a look at it again. So for the first question, what are some Latino cultural values that the provider could address in order to persuade Alex to share his diagnosis with his wife and family? The second question, what is a Latino cultural value that may attribute to Alex's refusal to say self-identity and a bisexual person? And how can the provider respond to Alex's confessions of homosexual behavior in a cultural competent manner? And we're going to discuss other cultural competence issues that may impact retention into care and treatment. So I'm gonna go ahead and get the timer started. And we also welcome, hi, I'm gonna ask to kindly please mute your line. Please, thank you. So yeah, you can raise your hand and you can also provide your responses in the chat. Thank you.
So Frida and I will be quiet for 3 to 5 minutes while you either write down your responses or you think your responses.
Of course, we encourage everyone to participate verbally. And here is case study.
All right, let's go over the questions video.
Yeah. All right. So we did have one response in the chat by Jessica Cromer. Jessica, would you like to elaborate a little bit more on your response for the first question?
Just from his background, the case study itself spoke about how he loved his wife and his children very much. So that kind of told me that that's the area that could be addressed to encourage him to open up to his family and be honest and open with them.
That's an excellent response, Jessica, and thank you so much for participating. The Latino community or Latino culture is very family oriented. And this is something that we need to explore in a case like this one, that the most important thing or the most important people for any Latino is their family. I see that I see as well that is mentioned the religious beliefs. That's something that can be addressed while having this conversation with the patient. But I do think, and I agree with Jessica, that the the love for his family is something that need to get explored. What is a Latino cultural value that may attribute to Alex's refusal to self-identify a bisexual person? Anyone?
I don't know, from my perspectives, yeah. Somebody mentioned in the chat machismo, Catholicism, same sexual practices like topping are not perceived as gay. Mhm.
And I agree with these responses in regards to the refusal. One is, as is mentioned there, the machismo, that the house, the culture identify someone who has a different way to see others, and the Latino culture is machista, is very patriarchal, where the man is the one who is going to bring food to the family, and is not seen well someone who doesn't follow sometimes the rules or the norms in the Latino culture. I agree that in the Hispanic culture, traditional marriage is between a man and a woman. That is a great response. And also, there are several ways and several in the society, there are several words that are used sometimes to refer to either someone who is bisexual or gay. And those are very offensive, and people try to stay away from any discussion on this topic. Now, how can get the provider respond to Alex's confession of homosexual behavior in a culturally competent manner? So what we need to analyze here is that it's not easy for someone to confess this. This is part of the internal self, how we see ourselves. But we need to make sure that patients understand that we are here to help them, that the same questions that you are going to ask are asked to all patients in general, regardless of the sexual differences. These are questions that you go over with all your patients. And Jessica is saying no bias or judgment, acceptance and understanding, but not shaming her patient. So those are really good responses and really good strategies when we discuss this issue with our patients. And then other cultural competence issues that may impact retention is language, any language barrier, whether or not this patient is with someone else is not the same when you have a family member in the clinic with a patient, that when the patient is just having this conversation with the clinician. And next slide, please. Next slide. So this is what we were discussing, how we are taking our sexual history from the patient and making sure that when we are going to introduce the questions, we tell the patient that these questions are not only for his or her sexual orientation, but these are questions that you ask to all patients, regardless of how they identify. And then we need to discuss the sexual orientation, the partners, even though in this case we know that the patient is married, he is also having sex with other men. We need to ask that, the sexual activity, what are the risks? And then we need to counsel the patient, either because we need to screen our patient or provide additional advice to our patient, depending on what the patient is looking for. Next slide, please. So in regards to HIV and the Hispanic Latino people living in the US, CDC is reporting that Latinos are more likely to be newly diagnosed with HIV. And there is also data that 24% of all people with HIV in the US are Hispanic or Latino. So this is wise. I mean, this is very important to know, because it's not that we are going to stigmatize our patients, but we need to make sure that we always address the issue with any patient, regardless of their religion, belief, or whether or not the patient is Hispanic or the patient is an African American or white. Next slide, please. CDC is also reporting that new HIV infection is affecting the Hispanic, Latino, and gay and bisexual men and heterosexual women in general. In regards to the heterosexual women, this is because cases similar to the one that we analyzed, either the man is not being honest or is not being faithful to his or her his wife, and that's the reason why many heterosexual women are getting HIV. And the other reason, and we need to keep this in mind, is substance use disorders as well. Again, we need to see our patients equally. Because a woman is a woman, that doesn't, because a woman is a woman, that doesn't mean that the patient cannot be affected by substance use disorders. So let's keep that in mind as well. Next slide, please. So this is part of the case study, and why we presented the case study first, because in the Hispanic culture, family, religion are very important, and it was these two were mentioned by you in the chat, specifically how the family culture and the religion are main values in the Hispanic culture that we need to keep in mind. Also, it's very important to understand that Latino or Hispanic is just a term that tries to bring together people who speak the same language, but in reality, depending on the region, you can have different patterns and different cultures and different beliefs. So let's make sure that you don't put all of them in the same bucket, because even in the Hispanic population, there are some nuances, or there are some differences that we need to keep in mind. Next slide, please. So the Latino culture have the same language. The family is very important, as well as the religion and spirituality. And the definition of illness, this is one of the biggest concerns, because if you are very familiar with the Hispanic population, before going to a doctor, they usually have received some advice from either a family member, or from the pharmacy, or from the depending on the culture, there are curanderos or curanderas, which are traditional healers. And when they don't get any better, then is when they come to the clinic. And then we need to understand that sometimes we see patients that with some complication of the conditions that they have, because they have the access to care has been delayed by any of these concerns. Next slide, please. The respect And this is something that I would like to emphasize a bit. The Latino population is very respectful, specifically with the seniors, with the parents. So is characterized by communication that is based on respect. So this is something that can affect our interaction with Latino patients, because if they perceive that they are not being respected, then that can be an issue when we have communications with our Latino patients. Next slide, please. And this is for those who are Spanish speakers, or for those who understand the language. There are several ways that you can talk to people. You are very familiar with someone. You can use either usted, or in some places in Central America is vos. And but if you have a formal conversation with someone, you have to use usted in Spanish, specifically if you are addressing someone who is older, or you have or you don't, or a person that you don't know or you are not familiar with. Next slide, please. This is just a map of Central and South America, showing the difference between how you can refer to someone depending on the age and depending on how the person is being affected. And I see a comment here. Howard University developed this resource on cultural competence on HIV and the Latino culture as part of our previous ATC project. Is also in Spanish. That is correct. That is correct, and this is something that is from the AIDS Education and Training Centers. Thank you for that. Next slide, please. Remember that if we don't get the respect, or if the patient doesn't get the respect that they need, what is going to happen is that if you can lose the communications, you can get stranded, and the patient is not going to come back, regardless of whether or not you are the best clinician in the area, regardless of whether or not the services that you provide are the best. The interaction is very important, and the way that you speak and talk to your patients are more important sometimes that any title or certificate that you have on the wall. Next slide, please. In regards to how a Latino community communicates, it's very important that from the very beginning, we develop a really good communication with our patients, that making sure that they understand us and that they understand and that we understand them. And we need to make sure that we have a chit chat, something as simple as, how are you, Mr. Rodriguez, how are you doing today? It's been a while since you came for the first time or for the last time. So that is something that is going to open the conversation. And when you have communication, and the communication starts well with the Latino community, you are more likely to get the responses that you need. We need to make sure that we personalize the conversation, that we are talking to the patient and the needs of this patient, and making sure that we are aware and familiar with the case and what the patient is expecting from us. And the Hispanic population expect the healthcare personnel to be warm and personal and express a strong need to be treated with dignity. This is extremely important as well. Next slide, please. So these are some suggestions again for respectful communication with older persons. Should be addressed by their last name. Avoid gesturing. Some may have adverse connotations. Make sure that that our patients understand our questions and our instructions that we've been going through training on health literacy, for instance, and making sure that our patients understand what we're talking and what they need and the instructions that they need to follow. And as always, our patients, do you have any questions? Is there anything else that I can do for you? That is very important, and it opens a door in case something has been omitted or forgotten when we have a communication with our patients, specifically the Hispanic population. Next slide, please. So let's make sure that we are discussing, that we have an open and honest discussion with our patients. And many culturally appropriate suggestions say that if there is any problem and if the person doesn't speak English or has some limited proficiency, making sure that we don't use any family member, specifically if we are going to discuss issues related to sexuality or STIs on HIV in this case, that we need to discuss with our patients. Next slide, please. Again, we were discussing that how important family is for the Latino population, and the family is based on the father and the grandfather and the grandfather. So it is very patriarchal, and we need to make sure that we understand that as well. Next slide, please. We also discussed in our case study what machismo means and the issues and why the society is that way, because there is a lot of pressure from men and from religion and from other groups that are not accepting sometimes something that is different or something that they cannot understand. So let's make sure that they understand that for in the Latino population is male and female. And even though now I've seen more people who are open to discussion, this is still a big concern among the Latino population. Next slide, please. Religion and spirituality, we also discussed that is very important, that this is something that we need to discuss, that we need to keep in mind when we have conversation with our patients, that is going to affect the way that they respond, the way that they understand the disease or the conditions, the way that they are going to react to any diagnosis that we provide. Next slide, please. And making sure that, since regardless of the other patterns or the other issues, cultural issues, religion is the first for those who are believers, because there is people who also don't believe, but for those who are believers, the faith in God is very important when you deal with a patient. And we need to make sure that we understand that, and that we if we are talking to someone about any condition, specifically difficult topics such as HIV and STDs or STIs, the religion is going to play a big role in how in the responses that we're going to get from our patients. Next slide, please. We have a case study. I think that we don't have time for this case study, so we are going to start our fourth and last session with this case study. And then we are going to hear from another health center who is going to provide their experience on how they provide culturally competent care to patients in the US-Mexico border. So thank you so much again for being with us. And if you have any other questions, please make sure that you also contact either FIDE or contact me, and we are going to be happy to help anyone. Unless there is any other questions or any other comments, thank you so much for attending this session, and thank you so much for being with us. And please don't forget the post activity survey. Your responses are very useful to improve our sessions or to make sure that we are addressing your needs. Thank you and have a great afternoon.
Thank you, everyone. We'll see you next time in our next session next week at the same time. Also, please make sure that you complete our post-evaluation survey. And see you all next week. Thank you.